So today we've got the pleasure of acid-base practice. It's kind of an important topic because it's very exam-based and it's clinical. You know, we sit at the bedside every ward round looking at acid-base. It can be a little bit dry as a topic, but it's just we've got to know. It's actually this before that. Yeah. And I'm conscious we're a different grade. I know everybody. Sorry, you're.
I'm MT2.
MT2. Same. FY1. I know that well. You're MT2. MT2. Okay. Yeah. This is an intermediate level. I might skip over some of it because some of it just may not be super relevant and time-wise, but I thought we'd try and cover some basic concepts. Because we use the carbonic acid bicarbonate buffer system most in our sort of structure and concepts of acid base, we'll concentrate on that, but look at some of the limitations, describe some of the primary acid base disturbances, have a chat around the compensatory mechanisms and how we quantify them. Think about the other things we need to look at, particularly in metabolic acidemias. Within the confines of the carbonic acid system, there are lots of caveats, and there's this new theorem. I say new, it's not new at all, it's been around since the 70s, but there's quite a lot of chat about it. It's still not something we use at the bedside, but just to have some concept of what it's about, a bit of a practical approach, and if we have time, we'll see clinical cases. So what do we, I'll just so don't pick on anyone. We'll talk about acid-base balance. If you had to define that in a nutshell, what would you say we're talking about in a sentence?
What is the pH of the body?
Kind of.
Yeah, acid or alcoholic water.
Yeah, okay. Anyone add anything to that? I mean, you're right. It's essentially hydrogen ion homeostasis, isn't it? And maintaining a very narrow window of hydrogen ion concentration because it's so crucial to so many metabolic processes, biochemical processes. So homeostasis of hydrogen ion concentration, fundamental to so many different biochemical processes. What's staggering about hydrogen ion concentration is the scale we're at. We're used to talking about millimoles of sodium, potassium, maybe micromoles of creatinine, but here we're dealing in nanomoles. So, you know, got to think of millimoles is 10 to the -3. This is 10 to the -9, so a million times lower quantities. And normal hydrogen ion concentration is 40 nanomoles. And you talked about pH, and we'll come to that. Most of us, and we all know what we mean by pH, and why we use the scale partly is because we're dealing with such small quantities. But the actual tolerance of hydrogen ion flux is quite large. Normal pH 7.36 to 7.44, and that equates to 40 plus or minus 5 nanomoles. So infinitesimal, you know, fine tuning of these concentrations, but quite a high turnover of hydrogen ions in the body through the kidneys, 150 millimoles a day. Most of that actually comes from ATP. Hydrolysis and dissociation of water. Water is the biggest supplier of hydrogen ions in the body, and the majority of that is then recaptured back into ATP. So we recycle our hydrogen ions through water, hydrolysis of ATP. So you talked about pH. What is pH? Moving on, I should know everyone's names. Sorry, I think. No, sorry. How would you define what do we mean by pH?
So like how acidic something is?
No, so mathematically. So the notation P is a negative logarithm of a number, and we use logs to the base 10. Don't worry, my maths isn't great either, but so it's a non-linear scale, which we'll see in a minute on the table. But because the numbers are so small, we do logarithmic scale, the inverse logarithmic scale, to look at hydrogen ion concentration. That's what basically pH means. So we said, why is hydrogen ion concentration so important? Well, for all of those reasons and a lot more. Fundamentally, proteins are affected by hydrogen ion concentration. It affects its ionization of proteins. So enzymes are fundamental catalysts to so many metabolic processes. Protein structures change. We know hemoglobin either takes up or gives up oxygen differently under different pHs. The Bohr effect, I'm sure you're familiar with. And intracellular processes, again, DNA, mRNA synthesis, are all fundamentally affected by pH. So, yeah, massively important. So that's the scale, and it's worth noting it's non-logarithmic. Sorry, it's non-linear, and it is logarithmic. Normal pH of 7.4 is 40 nanomoles of hydrogen ions. But if you look at a change, let's say between pH 7.1 to 7, that's a 20 nanomole change. But the same change from 7.4 to 7.5, a unit, is only 8 nanomole change. So it's a non-linear scale. As a general rule, what do you think the body prefers? Does it cope better with acidemia or alkalemia? Yeah, much better. It's very rare to see severe alkalemias. We do occasionally, but it's relatively unusual. The body would far rather deal with acidemias. I've seen patients with pHs of 6.7, which is off this scale, with loads of compensation, of course. But, a huge increase, that's a quadrupling of hydrogen ion concentration. The highest pH I've seen some 7.6s right now. What's the highest you've seen?
Yes.
It's very rarely above that. And so that's tiny change, actually, in numerical terms. So just bear in mind that relationship between pH and actual molar concentration. So a few definitions, I won't drag through this too much. If we were to just simply try and define some of these, what is an acid? Just in very, I'm a chemist, so keep it simple. Yeah, yeah. And what's chemically characteristic about acid? So we're talking about chemicals in solution. What do acids do? Yeah, they're hydrogen ion donators. They'll give up hydrogen ions. Solutions have a pH less than 7. Bases tend to be hydrogen ion or proton acceptors, and in solution they'll resist changes in pH. And in our carbonic acid system, it's about bicarbonate and the base that they can give off. What do you mean? What's the difference between strong and weak acids? Well,
Strong acids are dissociated.
Yeah. It's all about dissociation, isn't it? So strong acids like hydrochloric acid, sulfuric acid, nitric acid, they dissociate pretty much fully in solution, whereas weak acids don't. And we can talk about, we'll have a look in a minute at how that works and the acid dissociation constants. To be a buffer, you need to be a weak acid. Most physiological, in fact, all physiological acids tend to be weak acids. We don't have strong acids physiologically. Hydrochloric acid and stuff, I suppose, but they're essentially weak acids. Just a bit of other sort of terminology. People talk about volatile or non-fixed, and they are acids that are controlled or generated by CO2 and lung control of CO2, so basically carbonic acid. The non-volatile acids are either organic or inorganic. So organic examples would be lactate, keto bodies. Inorganic things like phosphate and sulfates. But a buffer is a system of the weak acid with its component base in solution that can resist changes in pH. And that's the carbonic acid system that we look at. But they're the kind of things you can get asked in vivas that can throw you if you've not really thought about it. Some other terminology that can, again, it's a bit pedantic, but people ask you to define. What's the difference between an acidosis and an acidemia? I'm being pedantic, but again, it's good vibe for them.
So acidemia, I think, is just with regard to the pH.
Correct.
But then when you have the systemic effect, the body got an effect as a result of acidemia.
Yeah, kind of. In my head, acidosis is the process. You have a metabolic acidosis and a respiratory acidosis, the process, where acidemia means the pH is less than 7.34. It's the state. Like hypoxemia is a depressed PaO2, whereas hypoxia is a process or is being driven by something. So acidosis is the process, acidemia is the state. Most people would define acidemia as 7.34 or below, or 7.35 or below. Alkalosis the process alkalemia above 7.44. What is the base deficit or excess? How would you define base deficit or excess? We always talk about a ward range, don't we? And it's on the blood gas printout, what it actually is. If I say this chap's been base deficit of 10, what does that actually mean?
The amount of bicarb needed to
Pretty good.
gauge.
Yeah, not bad. Anyone want to add anything?
Basically, the amount of acid or base that needs to be added to neutralize the.
Yeah, I mean, the first thing to say, it's the metabolic components of an acid as a primary acid-base disturbance. The definition is it's the amount of bicarb in millimoles you've got to add to each litre of extracellular fluid to bring the pH back to 7.4 in the presence of normal CO2. So the respiratory component's been removed by the machine. So if you've got a base level of -10 and your extracellular fluid volume is 60 litres, then you need 600 millimoles of bicarbonate in the face of normal CO2 to correct pH to normal. So at the bedside, it's the metabolic component. That's what you need to think about. The standard bicarbonate is the measured bicarbonate corrected to a PCO2 of 5.3. So it's a similar thing. It's showing you the metabolic component of an acid-base disorder. That makes sense? Do shout out now if you're doing something wrong, by the way. I'm no expert on this, so do chuck in your thoughts. So let's just have a quick thing. We talked about the buffer systems, and there are numerous within our physiology, but the carbonic acid system is the one we look at. And carbonic acid, H2CO3, that dissociates into hydrogen ions and bicarbonate ions, and is also formed from the dissolved CO2. In fact, dissolved CO2 accounts for most carbonic acid and most bicarbonate in our bodies. Those equals should really be the arrows back and forth, because that's sort of quantitative mass action effect. More CO2 pushes it that way, more protons pushes it that way. So we use this as kind of the underpinning of our acid-base analysis. And common sense tells you that's all we're using. It's a bit basic, because there are many other things that affect hydrogen ion concentration, which we'll come to. So we can derive an equation, which again, you'll all remember from your medical school or revision for exams, the Henderson-Hasselbalch equation. And again, don't want to drag this out and make it too painful. So this relates for a weak acid, the pH, the acid dissociation constant. Ka is the acid dissociation constant, which is a measure of how easily a weak acid dissociates. The lower the Ka value, the less it dissociates, the higher. When the pH equals the Ka, you'd be 50% dissociated. And you can derive the Ka. But the Ka, when pK equals pH, you have an equal percentage or ratio of your acid and your base, and you can derive that. So if we just look at this for the bicarbonate system, our acid is carbonic acid, H2CO3, our base element is bicarbonate. The pKa of this acid, which is a physicochemical property, is 6.1. We can plug in the numbers now. And as I've said, H2CO3 is almost totally dependent on how much dissolved CO2 there is. So you can replace that with CO2 times its solubility coefficient, which is 0.225 in kilopascals. Plug in your normal bicarb, 24, your normal CO2 of 5.3, lo and behold, you get 7.4, so a normal pH. So the normal circumstances of carbonic acid system, given its pKa of 6.1 with a normal bicarbonate with CO2, gives us a pH of 7.4. So what you can determine from this, the two major determinants of pH in this system are bicarbonate concentration and PCO2. That's what's driving this. And the hydrogen ion concentration is secondary to those two elements. That can make sense? So plasma pH is kept very constant, as we said, largely through generation of CO2, generation of bicarbonate in the renal tubules, excretion of protons in the renal tubules, and maintenance of PaCO2, which is, there's only two things that affect that. That's metabolic CO2 production and alveolar minute ventilation. But I do want to emphasize this is an oversimplified picture. There are lots of other things that act as buffers. Plasma proteins do, hemoglobin does, the phosphate systems do. So it is simplified. And we'll come back to that in a minute. One of the things I remember finding useful was the Davenport diagram. I think I'm familiar with it. Come across it ever? Something, I don't know whether you'd need it for in medicine, but certainly for anaesthetics. It's a graph that plots plasma bicarbonate against pH. Doesn't project very well, this. So we've got pH from, it goes down to 7, up to 7.8 nearly. Bicarbonate from 0 to 25. And then there's the various CO2s drawn on. So you're looking at three parameters that affect pH. The bicarbonate, the CO2, and then the pH itself. So if you've got a bicarbonate of 24, you've got a pH of 7.4 and a CO2 of 40 millimeters of mercury, which is about 5.3 kilopascals, you are sitting on this diagram in the normal range. Yeah. You can see the primary abnormalities, what happens on this graph. In an uncompensated metabolic acidosis where CO2 stays the same, you're going to travel down this limb. So you drop your bicarbonate and your pH drops with it. So you're moving that way on the horizontal axis and down on the vertical axis. Likewise, in early respiratory alkalosis, bicarbonate goes up and your pH goes up. And then you can see the primary respiratory acidosis with the CO2 increasing, moving from the 40 millimeters of mercury to the 60, and your bicarbonate goes up a little bit. And then you can see the compensatory mechanism. So in normal, in a normal non-anaerobic metabolic acidosis, you travel down this limb, and then to compensate, you drop your CO2, you bring the pH back towards normal. Remember, you never totally compensate. Compensation is always partial. You never actually completely compensate. I remember finding that useful to look at and get a sort of pictorial idea of what's happening to the two components that affect pH, bicarbonate and CO2. So I'd encourage you to have a little read around that graph. And again, it's a bit examining, certainly in anaesthetics and critical care. That's just another representation of the same graph. So have a look at that. As I've said, there's these other buffer systems with different dissociation constants. Phosphate acts as a big buffer system, particularly in the red cells. Plasma proteins are a huge buffer system, and also within the cells. So yeah, bear in mind the other systems that are running. That's just a graphical again, really, to show the two important organs that we think about as controlling pH, the lungs and the kidneys. Most of the carbonic acid sits in its base form. So bicarbonate is, in terms of ratio, about 20 to 1 to carbonic acid. So most of it is sitting as dissolved bicarbonate. So let's just have a little think about the sort of primary acid-base disturbances, and then I might regress it, but we'll talk about some of the compensatory mechanisms and how we evaluate them. We usually do it at the bedside just by eyeballing, but there are rules you can use. I'm sure you guys all know this, but just go through it quickly. So in a metabolic acidosis, we get an acidemia, the pH drops, and the primary biochemical change we see on our blood results is a fall in bicarbonate. Very rapidly, that will be compensated for a minute when you get someone with a lactic acidosis or DKA. They hyperventilate very quickly, and we see a drop in CO2. So that's the picture we expect to see in a primary metabolic acidosis with respiratory compensation. A rarer picture, but in metabolic alkalosis resulting in alkalemia, we have a raise in the pH and we see a raised bicarbonate. And the only response initially would be respiratory hyperventilation, relatively unusual picture clinically. Respiratory acidosis, very common, so a raised CO2 with a drop in pH. Within hours, you'll start to see renal retention of bicarbonate to bring the pH back to normal. And then the opposite, in a respiratory alkalosis, hypoventilation, it takes longer to respond, but you will see increasing bicarbonate elimination from the kidneys. That's the very sort of simple graph of what goes on. So when you're looking at a blood gas, try and work out what the primary process is. Is it an acidemia or an alkalemia? Have a look at the base deficit or the standard bicarbonate. What is the metabolic component? And then you've got to ask yourself, what are the compensatory mechanisms going on? Because you can have two processes. You can have DKA and someone who's attended with respiratory acidosis. So they might have a primary metabolic acidosis from DKA, but they're knocked off and they're starting to retain CO2. So trying to tease apart the different compensatory mechanisms. Most of us look, and after you've looked at gases for many years, you get an idea of what's reasonable. So let's say someone comes in with a DKA and they've got a base deficit of 20. I'd expect their CO2 probably to be around 3, something like that. If it was a lot more than that or less, you might be thinking, what's going on and why is it so different? That's in a non-ventilated patient, obviously. If they're not matching, you feel it isn't, the proportions aren't quite right, think of a mixed disorder. Has anyone come across the Boston rules for calculating the compensations? They're not very bedside friendly. There are 6 rules. They were described years and years ago, I think in the late 60s. And I'll quickly go through them. You can look them up. They're quite useful sometimes. If you've got a really tricky blood gas, you can Google these. They come up straight away. But they give you the proportion of change you see as a sort of compensatory mechanism. So we just start, rule 1 is about acute respiratory acidosis. So someone who's CO2 retaining. You would expect bicarbonate to go up in metabolic compensation. If it's relatively acute, you would expect to see an increase of 1 millimole of bicarbonate per litre. So you look at the standard bicarbonate or base deficit for every 1.32 increase in kilopascals above 5.3. And that's the calculation. Your expected bicarb will equal 24, which is what the normal bicarb would be, plus your actual measured CO2 minus 5.3 divided by 1.32. That will then tell you the amount of compensation you should expect to see. Don't worry about the maths, but that's the equation you can use. You see this happen quite quickly. Bicarbonate will increase quite quickly in acute respiratory acidosis. Next one is about chronic respiratory acidemia. So our COPD patients, chronic CO2 retainers, have a much greater compensation over time, and the factor's 4-fold. So rather than 1 millimole for every 1.32 kilopascals, it's 4. So you just see a much greater renal compensation. If you get your chronic CO2 patient coming in, they've got an acid-base disturbance, but you've got evidence they've been CO2 retained for years, you can work out what their bicarb should roughly be by using that calculation. So acute respiratory alkalosis, so you'd expect to see a decrease in bicarbonate, and it's 2 millimoles every 1.32 lower of your CO2. Chronic respiratory alkalosis, so chronic, I can't even think what conditions would cause chronic respiratory alkalosis. Any thoughts? I'll think of many. Chronic hyperventilation. Anxiety, yeah. So it's a 5-fold change. Metabolic acidosis is probably more useful because these are the ones we see most. So if you've got someone, let's say, a base deficit of 10, it's acute, and you want to work out whether the CO2 has dropped in a proportionate manner. If their bicarbonate, let's say, is 10, you'd expect to see 0.2 by 10, so a fifth, which is 2, you'd expect their CO2 to be 3, as a general rule. Yeah? Again, fairly rapid compensation occurs. You won't get your CO2 below 1.3. I have seen some blood gases from high altitude mountaineers where they get their CO2s down to 0.8, but it's, yeah, most patients won't. Young DKAs, I've seen CO2s sub 2, but you won't be able to breathe up a lot more than that. And then the final one is the metabolic alkalosis. Don't get fixated, be aware of them. And if at the bedside, if you have an interesting blood gas, occasionally, if you're trying to work out if there's more than one process, those rules are quite useful. Any queries on that? The two other things we need to mention that you're familiar with is anion gap and the osmolar gap. Any thoughts on that anion gap? You know it.
The difference between sodium and potassium minus chloride.
Yeah, what is it? I mean, why? So a normal anion gap is between roughly what, how many millimoles? A bit higher than that, 12 to 18, something like that. So where are these unmeasured anions? What's causing it? You're right about the equation. So it estimates unmeasured anions, and within our bodies it is normal to have 12 to 18 millimoles per litre of extracellular fluid. There's the answer for you. So we're talking about anions, so negatively charged particles. These will be associated with things like plasma proteins and then other inorganic molecules like phosphates and sulfates, and a certain amount of lactate is called normal lactate too. So we don't measure these, and when we do our anion gap calculation, which is that sodium potassium minus chloride plus bicarbonate, we see this gap. And 12 to 18 is normal. If it's more than 18, then there's either production of exogenous acid or production of endogenous acid, like lactate, like ketones are the two obvious examples, or there's exogenous acid being taken in. Any acidemia, just have a quick look very briefly at the anion gap, and I've got some sort of pictorials. If it's a normal anion gap acidosis, then you think about bicarbonate losses, often replaced by renal chloride retention. Increased anion gas acidosis, think about, as I said, exogenous, endogenous acids. So that's the sort of normal position we'd expect to be in. We measure most of our anions. If you include potassium, you could add in magnesium, because we get those on the gases. This is what we're not measuring coming from our proteins or sulfates or phosphates or normal lactate, and that's never greater than about 18. If we see this picture, we've got a drop in bicarb, it's because there is another acid that we're not measuring, and the bicarb is buffering it and reducing quantitatively with that acid. And the two obvious examples, as I said, yeah, DKA, lactic acidosis. Let's just go through a few examples. So high anion gap acidosis, overproduction of acid, break it down into endogenous or exogenous, DKA and lactic acidosis. People used to talk about type A lactic acidosis, which is a drop in overall DO2, global oxygen delivery to tissues, which we see quite a lot. Or things like sepsis, where there's a cellular dysoxia and you're not metabolizing oxygen normally. Or scenarios where there is a normal DO2 delivery, and it could be ischemic tissues or drug-induced things, organ failures, starvation, ketosis, that kind of thing. There's a long list of the exogenous ones, but think of the soluble alcohols, the ethylene glycol, glycerols, and other drugs like salicylates. Renal failure gives you an increased anion gap because of the uremia. So that's another example of an increased anion gap acidosis. There's just a couple of weird acronyms. I think I prefer the CUSMAL one because of the name, but it covers off most of the ones that we tend to need to think about. I break down normal anion gap acidosis into either bicarbonate loss or additional acids. Bicarbonate loss is by far the commonest. So loss from the gut is not uncommon, and then renal failure, uremia, which actually contributes to an increased anion gap, but failure to generate bicarbonate or excrete hydrogen ions in renal failure. Don't forget, occasionally people are on carbonic anhydrase inhibitors. People familiar with the osmolar gap, so they have to measure that. So that is unmeasured solute contributing to an acid load. So calculate your plasma osmolality, how do you do that? How do you do a bedside osmolar calculation? Anyone help?
2 sodium
Plus glucose, yeah, that gives you a fairly close estimate. And then you've got to send off a sample to the lab for a measured and you're looking for a significant osmolar gap, which gives you the clue that it can be things like methanol, ethylene glycol, formaldehyde, those sorts of toxins that people take. There's often clues of, alcoholics, people's rough living. You can get sort of pseudo causes, grossly elevated lipids, paraproteinemias, any other solute that you've not measured. You see hyperglycemia much more obviously on your bloods. But if it's unexplained, check your lipids, check the paraproteins, because they can do the same thing. We've kept sort of talking about this carbonic acid bicarbonate system, doesn't tell the whole story, it doesn't, and there are certain things it can't sort of manage well, and hyperchloremic acidosis is one that we see quite a lot of. So there is this, again, don't want to stay on this for too long, but the bulimic status, your plasma protein levels, all contribute. Chloride contributes. We don't tend to include that in the traditional acid-base analysis. And this system attempts to look at the more holistic global picture. And there are three things that you can calculate: something called the strong iron difference, something called the total weak acids, and then CO2 plays this part. And they're called the independent variables. They are what they are, but they will have the effect on your hydrogen ion concentration and your bicarbonate concentration. Just out of interest, SID is calculated by that. So it's a kind of extended calculation of the anion gap in many ways. A high SID will lead to an alkalosis and dehydration. So you'd be familiar that dehydrated states often associated with alkalosis, whereas hypovolemic states are often associated with acidemia. And it's to do with total body sodium, a lot of it, and this is what these calculations are looking at, but you also include chloride. Not a friendly thing to use at the bedside. The ATOP is looking at total protein concentration, and because it's a massive buffer system in the body, and then you look at CO2 again. The actual total result of that equation is horrendous. It's not a bedside friendly tool, but it's a concept worth being aware of. I'm sure there must be online algorithms to use it. You need to put a lot of data in, but the chloride acidemias are worth bearing in mind when you think about if it doesn't fit the traditional carbonic acid sort of model. I think I just want to emphasize this. I always say a blood gas is not a patient, it's not a diagnosis in itself. Have a look at the total patient. You're going to examine a patient, get a diagnosis. Too many times people will ring us up and start reading a blood gas. You want to know what the diagnosis is, what's driving this. You can have a whole set of blood tests, including a blood gas, and assess in totality what you're seeing. In terms of the actual blood gas, assess the primary abnormality, which you need the pH, the bicarbonate, the CO2 and the base deficit, or the standard bicarbonate. Is the patient acidemic or alkalemic? And then what is the process? Is it a metabolic process or respiratory? And what is the compensatory process, as we've kind of discussed? I think we've kind of done this. The only thing I'd add in here is we talked about metabolic, normal or abnormal anion gap. We don't do this at the bedside much, but if you do see metabolic alkaloses, they're often associated with chloride depletion and hypovolemia, and chloride-sensitive metabolic alkalemias. You can work that out by looking at urinary chloride. If urinary chloride is less than about 20, and the kidneys are retaining chloride, they'll almost certainly be chloride responsive. So give resuscitative sodium chloride. If their urinary chloride is high, they're probably not chloride responsive, and it'll be another process going on. And then you've got respiratory acidosis, respiratory alkalosis. And I think when you look at the blood gas, those are the 4 questions. If you ask those 4 questions in sequence, what's the pH, what's the bicarbonate, base excess, therefore what's the primary process, what's the CO2, and have a think about the anion gap, and if it's relevant, the osmolar gap, you'll get to the bottom of most acid-base disturbances, I think, without wishing to get too clever about it. Yeah, think about the anion gap, maybe the osmolar gap, and things like ketones, toxicology. Kind of mentioned that if it's a metabolic alkalosis with abnormal chloride values on your U's and E's, think about doing urinary sodiums. Under 20, they'll be almost certainly chloride responsive. It's usually GI losses, things like diuretics and renal hyperperfusion can also do it. But patients are usually clinically hypovolemic. If you're retaining, if you're still excreting chloride in the face of metabolic alkalosis, you've got to think of weird stuff. Hypovolemic states associated with endocrine conditions would be one example. Any questions so far? Quite a lot to take on board on a sunny day. Let's just finish by looking at a couple of examples. They're not complicated, but what do people make of this? So we've got an elderly man, he's had profuse diarrhea following antibiotic treatment for chest infection, thirsty, lightheaded, and there is blood results. Yeah, so just justify that. So his pH is depressed, so he's definitely acidemic.
The bicarb is reduced as well.
Good, so he's got a bicarb of 17. What I haven't put on there, you would want to see the base deficit, but the base deficit would be low. Any compensatory mechanism?
CO2 is in the normal range, so it's not compensated.
Yeah, I would say that CO2 is a bit depressed. Would it be proportionate to that? Probably, but you could apply your Boston rules if you weren't unsure. Anything in the user needs?
Looks like he's got a bit of AKI.
Yeah, absolutely. So he's slightly raised urea and creatinine with a depressed EGFR. We don't know whether he's got to go CKD. So we've answered the first few questions. What's the pH? Well, it's low, so he's acidemic. The bicarb is depressed and the standard bicarb would be low, so it's a primary metabolic process causing it. There is a degree of compensation. I probably think it's proportionate without adding in the Boston rules. What was the anion gap?
16.
Sorry?
Roughly 137.4 minus 121.
Yeah. Yeah.
Still normal-ish.
So it is normal-ish, isn't it? So what do you think the acid-base disturbance is here?
Likely bicarb loss.
Yeah, it's got bicarb loss. So it's a normal anion gap, acidosis, metabolic acidosis, probably secondary to gut bicarb loss. Whether this bloke's got CDT or something, who knows? And he's partly respiratory compensated. What about this one? So 25-year-old mechanic comes in confused and drowsy into ED, and those are his initial result.
Acidosis again would correct.
So severe acidemia, bicarb of 5.3, so hugely depressed bicarb. Compensation?
Yes, that's very
Yeah,
Probably appropriate. He's breathing pretty hard, isn't he, to get CO2 down to 2.5. His ketones are normal. What's immediately making you think? His chloride is incredibly low, isn't it? So this is going to be what? It's going to be a high anion gap acidosis. What else would you want to do, possibly?
Toxicologist?
Yeah, you'd want to do an osmolar gap. So this was a blood gas of a patient who'd taken ethylene glycol and had a raised osmolar gap. And those very low pHs, and again, you're fitting it into the clinical picture. Treatment for that? Yeah, omeprazole, isn't it? I mean, we used to give, alcohol dehydrogenase with ethanol infusion. I think now you use omeprazole and you aware of any other major treatments.
This guy would come to IT or no?
Yeah, probably. Yeah, I mean, these patients have a high mobility given some base disturbance that I take in. Yeah, definitely glycol those three. Yeah. And if you don't treat quickly, I mean, obviously retinal damage, blindness, but severe liver failure. And final one, lady being treated on CCU for congestive cardiac failure. After several days of treatment, we've got the following results. What do people think about that?
Alkalotic.
Brilliant. Alkalemic. So with an alkalosis process, and she is very alkalemic, pH nearly 7.5.
Low potassium, low chloride.
Yeah, so we've got potassium with 3, quite a low chloride. We've got renal function, not too bad, is it? We've got a significantly raised bicarbonate.
Hypochloremic.
Is it what, sorry?
Hypochloremic.
Hypochloremic. It could be. That wouldn't quite fit.
Is it diuretic?
Yeah, it's a contracted circulation. It's a classic kind of hypovolemic alkalosis secondary to diuretics. So it'll be chronic. Again, if you measured a urinary chloride, it would be low, and she would probably respond to sodium chloride. Quite an unusual clinical picture. We've rattled through that quite quickly, haven't we? Sorry.
Sorry, I just wanted to ask a couple of questions.
Yeah, cool.
I've seen a lot of patients in ACV or in respiratory modes. They are coming with type 2 respiratory failure, respiratory acidosis. We put them on NIV, and after a few hours of NIV, when we repeat the gas, they go into respiratory acidosis. And that's what I wanted to ask. Like when the pH goes more than 7.45, like, so do we then increase the IPAP just because?
Yeah, I mean, the purpose of NIV in hypercapnic respiratory failure is to bring the CO2 down. Now you need, again, it's going to be history based. If the patient is a chronic retainer, you may not be able to bring that down to 5.3. In my experience, it's relatively unusual to bring those patients to a hypocapnic state on NIV. But yeah, you would titrate the IPAP to reduce the minute ventilation. You wouldn't want to overcompensate in that situation.
And if we leave them on the same setting and don't do anything, does that do any harm, or we have to bring it down to?
Well, I think the danger would be you could remove their CO2 drive. They might become apneic, will be one problem. If you did that chronically, they could become hypocalcemic and get sort of fetal spasm. I wouldn't be comfortable leaving them significantly hypocapnic. I don't know what anyone else's thoughts are. I would definitely reduce the IPAP. And you don't want to expose the IPAP if they don't need it. I would just aim to normalise the pH. Don't target the CO2, target the pH on NIV. And 7.2 and above is what your sort of usual target is. But I wouldn't overcompensate in that situation. I would reduce the IPAP definitely.
And then the other thing that I've seen a lot in ACV is someone that comes in has got mixed acidosis, so CO2 is high and bicarb is low. And in those patients, do you start the NIV for the respiratory acidosis, or you?
So for me, that would depend on what the cause is. So if you've got someone coming in with, let's say, a uremic acidosis from renal failure, and they start to become clinically uremic and obtunded, I would want to treat the underlying cause. NIV in that situation is treating a sort of secondary symptom of the problem. If they were a candidate for ICU, that's the kind of patient that I want to intubate. I mean, DKA is a good example. I mean, one of the sort of last marks of deteriorating DKA is a raised CO2. And problem you have in DKA is if you intubate and ventilate those patients, you will not get their CO2 as low as a young fit person will. But once they start becoming, if the raised CO2 is because of obtundation and reduced respiratory effort, by and large, you're going to intubate and ventilate and then treat the underlying cause. You could trial NIV, but it's risky. It's risky. I mean, what would you do in ACV for that? Would you?
So I've seen a few consultants just treating the high CO2 because normally some of them come with the low GCS. So they treat the high CO2 with NIV, and then once the CO2 normalizes, then they see the gas. And if it's a primary metabolic cause, they would just take the NIV off.
Take it off, yeah. I mean, if it corrects quickly, that might work. But it's a secondary process, isn't it? Treat the underlying problem, they might need some NIV support. If they're for full escalation, that kind of patient, I should probably be better referred here and consider them for intubation. As I said, the DK scenario is the difficult one. I've seen a few younger people who are coming in with, pH to 6.8 and their CO2s of 2, and they start to decompensate and get tired, and that's a dangerous. No mechanical ventilator will get your CO2 down to 2. So you intubate them, the CO2 goes up, and then the pH drops below 6.7. So that really is a tricky situation, and you want rapid correction of the DKA process.
So do you have a high or a low threshold for tubing?
Very high for DKAs. And we've had this a number of times in ED with people with consultants seeing us to intubate, or sometimes you guys going down there. And because they look at tunded, they're sort of what airway protection, which I kind of get. But I would don't get me wrong, if the patient is less than GCS 7, you're going to have to do something, aren't you? But you end up in a very tricky position where the CO2 will climb on mechanical ventilation and the pH will drop even further. So I would try and avoid intubating DKAs and just be very aggressive with DKA resuscitation and insulin regime where possible.
And the other thing that I normally quite commonly see in DKA patients is that they go into hypochloremic acidosis, and then
Why do you think that is? We give what is normal say,
So like, what do we do? So if they're not coming, the pH is not getting up because it has hypochloremic acidosis, then what do we do?
I mean, the rationale of sodium chloride in the first instance is these people often sodium deplete initially. Obviously, sodium chloride is the most effective resuscitation of the extracellular fluid volume, where all the sodium is. I do think starting sodium chloride is right, but do monitor the chloride, and we would then switch to plasmolite earlier on. They are sodium deplete, they'll probably be chloride deplete. It's definitely the right fluid to start with. But my view on DKAs is you need an arterial line to look after them properly. And unfortunately, ACB, I know one of your colleagues was very keen to get a protocol of an SFP for heart lines and ACB. I'm not sure Nigel Langford was fully on board, but to manage a DKA, a severe one, which really means pH below 7.2, you need hourly blood gases. You need to be watching the ketones regularly. You're using a fixed rate insulin regime, so you're watching the glucose regularly. You obviously come to the point where you've got to start adding in glucose until the ketosis is switched off. I've got a really, I think I have it in I have a low threshold between DKAs up here, just so you look at some ACB, you're doing venous section every 5 minutes. An arterial line is a really useful thing to have in for DKA. And then you can monitor your chloride, exactly the problem you're describing. You can start giving glucose when it's needed. And just stay on top and avoid that hypochloremic situation. Yeah.
So other than plasmolite, can you give any other fluid to put into?
Yeah, I mean, you obviously not going to get glucose straight away. Obviously, the problem with DKA is your intracellular space is hypoglycemic. All your sugar's outside, and what you're trying to do is get as much insulin as possible to drive glucose back into the cells. The reason, obviously, you use a fixed rate is you're not targeting extracellular glucose. So in our regime here, I normally, once the BM drops towards about 12, I'd start giving glucose as a secondary fluid. So you keep resuscitating the intracellular space with insulin and glucose. At that point, I might consider stopping the sodium chloride, but I do exactly what you said. I watch the chloride. When that starts to go up, I go to plasmolite. So sometimes with that, someone on, if you're still in the aggressive phase, literally 250 an hour after the first few litres have gone in of sodium chloride, the blood glucose drops. You then start 5% dex, maybe at 100, so you bring the sodium chloride down to 150. And then if you see a chloremia developing, change the normal saline to plasmolite. That's the kind of regime I'd go with. I don't know what you guys would do, but to monitor all those elements, glucose, ketones, chloride, sodium, I think you need to be in a level 2 setting where you can put an heart line in.
You see like dartboard.
It's horrendous, yeah. And to avoid that scenario of the patient decompensating, what keeps these people alive is their respiratory compensation. So you really want to get on top of the ketosis as quickly as you can. Yeah. I think it's a really satisfying thing, 3 DKA. I quite like bringing them up. They respond quickly usually, and it's a nice bit of biochemistry to chat about. Yeah.
What group of DK do you consider bicarbonate? Because on here the other day I saw they used a bit of IV bicarbonate on it.
I think that's really controversial. Who did that?
One of the branches on here.
Okay. Your measured bicarbonate is low because the bicarbonate is buffering the ketone bodies. You're not technically bicarbonate depleted. I wouldn't give bicarbonate because you'll further stress the respiratory system. Because obviously some of that bicarbonate will become dissolved CO2. That's a really interesting that you noticed that. I can't remember the last time I did bicarbonate.
I think I was surprised it was used, but I didn't know if it was
No. Interesting in that trial that Catherine talked about, DK was an exclusion for giving bicarbonate. My personal view would be don't give bicarbonate in DK. I don't think it has a place. It's a good question though. But there may have been another reason in that case. I wouldn't.
One of my last ever medical internship, there was a patient who had a DK.
Your last ever, you're not going back to.
No, I'm not a medical assistant.
Okay, sorry.
So,
Can you scan that, guys, by the way? Sammy Whitman murdered me if I don't.
So the patient came in with DK but had an AKI as well. So it was numbered AK stage 2-3.
Yeah.
And even after treating the DK for more than 24 hours, the pH was not coming up, and then we realized the glucose was normalized and the ketones were normal. And we thought that the pH is likely because of the AKI.
And was there a significant uremia? Was there a...
There was. So she didn't have any bloods before coming to the hospital, but when she came, there was quite significant drop in GFR and the uremia as well. And in that case, we gave her some bicarbonate, but that was not for the DK.
It was for the uremia. No, I think that sequence of events makes sense. I want to treat the DKA first, and then if you then got a renal acidosis, then giving bicarbonate is perfectly reasonable. And again, that trial would support that. And the renal physicians, as I said, have been doing that for years. And certainly, we're getting the hint now. I think Mosaic will probably tell us we probably overfilter, and actually a bicarb infusions for some of these people, particularly in sepsis, can help. Sorry, that was a bit rushed, guys. It's one of those topics that can become. Sorry.
So just a quick question regarding the best cases.
Yeah.
Clinically, how would we get a patient? Should we just focus on managing the primary problem rather than maybe focusing on the best cases, or is there anything we can do?
So I think you use the basic success to guide you what the primary process is. So obviously basic success, base deficit are the same thing, and negative basic success and base deficit, so they're the same thing. Just use that. That is a derived parameter. It's not a real physiological position. Look at their real bicarbonate. That's what's going to be affecting them physiologically. The base deficit or excess from the blood gas machine is derived by, as we said, normalising the CO2 and calculating how much bicarbonate they're missing per litre of extracellular fluid. I just use that as a guide as to what the primary process is. It doesn't really guide your treatment. So let's say it's a renal failure patient, they've got a very significant base deficits and their bicarb's low, then you would consider bicarb replacements. So it can guide you in that sense. Yeah. But it's not a diagnosis, it's a physiological parameter derived by the blood gas machine, which gives you an indication of the primary process. Does that make sense? Yeah. So I don't think any base deficit would guide specifically what you do in itself.
Should show you at least the progress of your
correct. Treatment. Yeah, absolutely. Well, absolutely. Yeah. Honestly, it will give you an idea of the resolution of the underlying problem. Yeah, absolutely.
Thank you.
Thank you.
Thank you, guys. I don't know if anyone was actually at Glenfield or anyone else still on the call? We're all bailed. Let me know if that was useful. Again, I meant to do a bit more clinical sort of cases, but for various reasons didn't get around to it. Would you rather, with that kind of talk, more clinical based? I just think you've got to do the basic physiology is useful. certainly, and I know there's no